afternoon. I'm Dr. Ossama Gaber, Chair of the Department of Surgery at Houston Methodist. I'm a Professor of Surgery at Weill Cornell Medical College. I would like to thank the organizing committee and the session chair for having me speak on the immunological challenges of the sensitized patient. The HLA system is a very pleomorphic system in humans. The discovery was made by Jean Doucet many years ago when he found that sera from multi-transfused patients and multiparous women could selectively agglutinate blood from diverse donors. This led to the discovery of the HLA complex, and it was noted that this HLA complex sensitization, or the presence of agglutinating sera, were associated with skin rejection loss in mice transplant. So that has led into a lot of research into the area of HLA sensitization. The HLA complex itself is expressed on chromosome 6, as you can see in this diagram. It's a very dense structure that contains more than 200 genes. It's actually interposed between the genes of tumor necrosis factor alpha and the HSP heat shock protein 70 and the CYP21A and the CYP4A. So these are all very important genes in terms of determining the immune response, and the HLA genes are lying in between them. They consist of 17 gene loci with over 16,000 alleles. These big numbers indicate the pleomorphism that complex, the HLA complex, has so many variations, which of course we observe in clinical practice. It is inherited under the Mendelian principle of gene inheritance. We know that because when we're doing a living donor transplant, we see that the children and haplotypes of the parents or the siblings are haplotypes, so they're taking one half from the father and one half from the mother, just like should happen in Mendelian inheritance. However, we also see cases of linkage, disequilibrium, and crossover events. So it's not necessary that you get the whole haplotype. Sometimes you get parts of the haplotype in the inheritance. And this is the HLA complex is very important for the adaptive immune system, which is the way by which we respond to foreign antigen, including transplantation antigen. I thought I can give you very quickly sort of the modern imagination of the knowledge of the HLAs. So HLA class 1 has 2 alpha chains. These are very pleomorphic. They change in the structure in that groove that is marked by the red line. The beta-2 microglobulin is constant, but you have an alpha-3, alpha-2, and alpha-1. Now, in this groove sits the peptides that come from the HLA complex, and these are called class 1 proteins. And the variation in the number of attachments that can happen to this groove are so variable to the extent that you can have 8,500 proteins in the base of that groove, creating the identification of numerous HLA molecules. Very similar with class 2, with the exception that it has an alpha and beta chain. There are over 4,200 alleles, 3,000 proteins. In the peptide groove, now it recognizes 13 amino acids. The difference between class 1 and class 2 is class 1 is expressed on all cells in the body, including platelets. But class 2 is only expressed on selected cells, specialized cells, maybe the base cells, for example, but it can be expressed on endothelial cells if there's stimulation of these cells or ischemia. And each cell can express up to 12 different class 2 molecules on the cell surface. This is a picture of the first multi-organ donor transplant that was performed by Dr. Michael DeBakey here at Methodist Hospital, where I work. And we know that in the 20th century, there was significant development in surgical techniques, so we started doing transplants. We recognized that in some cases, you would put the transplant, it turns pink for a while, and then within hours, the transplant dies off, so there's rapid graft loss. But we also knew that you can succeed in identical twin, and that's the transplant that Dr. Joe Murray got the Nobel Prize on for doing at the Brigham. we started talking about that the body is rejecting the transplant, and that's called rejection-mediated immune loss. And we started under the influence of people like Roy Kahn and others to develop new immune suppressants to treat the transplants. The basic discovery came from Terasaki's lab when he published a study in 1969. He looks at 225 kidney transplants, found that the rate of hyperacute rejection was at about 15%, and that the cross-match test that he devised was able to detect those with pretty good sensitivity and specificity. And he said that the ethics of transplanting kidney without knowing the results of the lymphocyte cross-match are ethically questionable. And this has really started the era of doing cross-matching prior to transplantation, so we can exclude the kidneys where the donor and the recipient, but the recipient has preformed anti-HLA antibodies to the donor HLA type, which results in rapid, either hyperacute or accelerated acute rejection. So we've now since known that HLA matching really is associated with better outcomes. So if you're a 6 or a 12 HLA match, that you get much longer long-term survival, although you don't get 100% survival because rejection can still happen because there are non-HLA antigens, which we're not going to talk about in this lecture, that actually cause rejection. But then there are patients that are sensitized, and when you test their blood, they do have anti-HLA antibody. These are usually people who've had prior blood transfusions, women who've had children, because they are acquiring the HLA type through the placental circulation, or of course, people who've lost transplants before. There are other people that have anti-HLA antibodies that we cannot explain, and usually this is related to either a viral infection or some stimulation by viral antigens. So one of the reasons our knowledge in this area has expanded significantly over the past few years is the evolution of the HLA antibody detection technology. So in the past, we used to use the Terasaki method, which is cytotoxicity assay. You put serum on the lymphocytes, you add complement, and then what happens is the HLA antibodies attach to the cells, the complement puncture a hole in the cell wall, and the cell dies. And you can enhance that by adding AHG, which makes, instead of one molecule of antibody binding, you can bind more molecules. You get rapid or faster or more pronounced cell death, and that's called enhanced cytotoxicity. In recent years, we've all been going to flow cytometric cross-matching, and that once you incubate the cells and the antibodies, you don't have to depend on the lysis of the cells. Just the attachment of the antibody to the surface of the cell can be detected by the addition of a fluorescein marker, and you can see it on the flow cytometer. And we call that sort of the channel shift. So if you have a lot of light, the channels have shifted a lot. If you have a little bit of light, the channels have shifted a little. Or if you have no attachment, then we call this cross-match as negative. So this is really give us a much more quantitative tool to look at cross-matches and distinguish people with small level of antibodies from people with higher level of antibodies. As you move across from cytotoxicity to enhanced cytotoxicity to flow cytometry, you're detecting smaller and smaller amounts of antibodies. But as you move from flow cytometry to cytotoxicity, you're detecting more and more important antibodies that can cause clinical outcomes such as rejection. So we've learned to titrate our sort of determining whether or not to do a transplant based on the flow cytometry, based on the amount of antibody that is present. Additionally, we've developed these Luminex-based antibody determinations. In the past, to detect antibodies, I remember that when I was a young transplant surgeon, I'd go to the HLA lab and they would draw my blood once a month, and they put me in what they call the HLA panel. And every recipient that was up for transplant, his blood or her blood would be tested against a panel of 30 to 35 people, and then a percent panel reactive antibody. If you reacted to 10 out of 30, that's a 30% sensitization, for example. And we don't do that anymore. Now we put the blood on these beads. And what happens is these single antigen beads, each one of them has a multitude of antigens on it. And then you add the antibodies, the blood, and then you add phycoerythrin, which is a fluorescent tag. And when you do that, then you can tell by knowing which antigen is in each bead. The computer does that, of course, because there are thousands of antigens on the bead. But the computer can look at the repetition of the antigen and says, yes, in every bead that there was an A2 antibody, that serum bound to it. So this person has an A2 antibody. And the degree of fluorescence, which we call the MFI, the degree of fluorescence is 2,000, 3,000, 4,000, 10,000, 20,000, and so forth. So now not only can we figure out to very great specificities which antibodies exactly do you have long before we do a cross-match, but we also can figure out the degree by which you have these antibodies. And this is very important because now we can do something called virtual cross-match. In the virtual cross-match, if you've characterized all your patients' antibody titers before you even have to do a cross-match, you can look at an HLA typing of any donor, and you can predict the cross-match because you would know whether there are DSAs, what the levels of them are, whether or not they're going to cause you to have a positive cross-match. So we can do something called virtual cross-match without having to do it in the tube. And there have been quite good papers that show that virtual cross-matches has very high sensitivity and specificity. Of course, this couldn't have been done without the single antigen beads. Another very important thing about single antigen beads really is that you can actually distribute between the different alleles of the antibody. So if you look at the binding of the HLA molecules to the antibodies, a very small change in the allele, like if we now, because we do molecular typing, we can tell that if you have an HLA B7, your B7 is B702, B703, B701. Each one is slightly different than the other. And this technology can tell us which B7 allele your antibody is binding to. So we can actually say that even though you're a B7 and the donor is, you have B7 antibodies and the donor is B7, these are allelic antibodies and they're not going to cause a positive cross-match, which is a great advance. We've transplanted many patients that we would have if we just did flow cytometry or if we just did cytotoxicity, we wouldn't have been able to tell these allelic differences. Another important thing is we know that C1q, which is the complement activation, C1q antigens can be detected by looking at IgMs and not IgGs. And that actually gives us an idea about the antigen density and its impact on the graft. So if you look at this curve, you can, on the top, you see the flow cross-match and single antigen beads. Both of these things measure IgGs. So we know that no risk, you're under the limit of detection. But as you continue to increase the limit of detection, you get, these are the DSAs, you start getting weak positive flow cross-match, then positive flow cross-match, then you get a CDC positive cross-match. So the sensitivity is very high at the weak levels, the specificity is very high at the high levels. And of course, the C1q measures complement, membrane-bound to IgG or IgM. And again, the limit of detection and the positive cutoffs are the same. But when you have C1q antibodies, very early on, the limits of sensitivity and specificity match, and this is quite a high-risk transplant. So what is the impact of the test sensitivity? I've been talking to you about sensitivity and how you start from just knowing that you have antibodies, low MFIs, the MFIs increase, now you have a positive flow cytometry cross-match, the channel shift can increase, now you have a positive cytotoxic cross-match. And this study has been done in about 10,000 patients. And they looked at them and they really divided them on their positivity, either by the Luminax, or by the flow cross-match, or by the CTC, to look at the different sensitivities of the assay and the result of their outcome of the transplant result. And you can see people who have no DSA have the best outcomes at 5 years. So the rejection rates or the graft loss rates at 5 years is about 15, 16% for people who have no DSAs. If you have only DSAs, low titer DSAs that are not causing a flow positive cross-match or a cytotoxic cross-match, just DSA, so probably Luminax assay levels between 2 and 6,000 or so, these have almost similar results to patients who have no DSAs. Once you start having positive flow cytometry cross-match, wherever your channel shift cutoff is, but once you determine that this is a positive flow cytometry cross-match, then actually at 5 years, the rate of graft loss is about 25%. If you have a cytotoxic positive cross-match, so that's the Amos or the modified Amos cross-match, if you have one of those that is positive, the rate of graft loss is about 40% at 5 years. Clearly, if we look at this, we want to transplant people who have no DSAs and people who have DSAs by Luminex but no flow cytometry cross-match. But we have to also pay attention to the fact that the patient mortality is also important to factor in, right? Because here we know that people with no DSA and very low levels of DSA detected by Luminex have identical survival at 5 years. So the patient mortality is about maybe 12, 13% at 5 years. If you have a positive cytotoxic cross-match, the mortality is almost 18, 19% at 5 years. So that makes you really hesitate or think twice about doing a transplant with a positive cytotoxic cross-match. I just want to remind everybody that the mortality on dialysis is about 7 to 15% a year. So without transplantation, the mortality in 5 years for these patients is almost 25%. So that any transplant seems to be better than no transplant. Of course, we don't want to do transplants where the patient mortality is as high as 20%. So what we want to do is we want to desensitize these patients so that these positive cytotoxic cross-matches can come close to these positive flow and no DSA cross-matches. So what do we have now as options to do for these very highly sensitized patients? We can wait for a compatible donor. Of course, you have a cadaver list, and you have very high level of antibodies. The waiting time is high. I mean, I've had patients that have been on the waiting list 12, 15, 16 years. The problem is these patients are so unlucky that the time an organ is identified and you want to transplant, they're probably not transplantable from significant cardiac morbidities and so forth. So waiting alone is not a good strategy. If you have a living donor with a compatible paired exchange, we have one of the largest paired exchange programs in the United States. We do direct pair exchange, or what we call swap transplants, where we create circles of transplants that end up with an open chain where there's another altruistic donor that goes into another chain. And these can help you overcome not just HLA incompatibility, but also ABO incompatibility. Now, some patients are so highly sensitized, even with the very active swap program that we have, still wait for a long period of time on that. So we try to desensitize them and mix desensitization together with paired exchange, or just do desensitization alone if the antibody level is not very high. And I'm going to discuss with you now the types of protocols that we use for desensitization. Now, we know that these living donor incompatible transplant, this is a paper we published with Montgomery many years ago. We looked at living donors that are incompatible, that we desensitized with plasmapheresis, IVIG, and rituximab, and compared them to the patients who stayed on dialysis, then had a transplant, and the patients who stayed on dialysis forever. And you can see that even though you get an early rate of rejection of the transplants after a desensitization protocol, in the long term, people who got desensitization fare better than people who stay on dialysis in terms of mortality. Now, one of the major advances in the past few years have been the recognition that not all donor-specific antibodies harm the transplant. And this is a study that was published in 2016. It's a multi-center study that was done in Europe, where they looked at CD30 positive and CD30 negative patients who have DSAs and who do not have DSAs. And they looked at the outcome of their allograft transplants. So patients who were transplanted with DSAs were very similar to patients who were transplanted without DSAs if their CD30 was negative. If their CD30 was positive, now CD30 is a marker of immune activation of the T cells. So now it indicates that that patient not only has DSAs, but also has an active immune system. And with the CD30 positive, and in the CD30 positive patients, if they had DSA, the outcome of the graft was much worse than without DSA. And this was also not just in class 1, but also with class 2 antibodies. So we now know that immune activation in dialysis patient happens. Some of them get activated because of bioincompatibility with the membrane. They have intercurrent infections that their immune system responds to. They have autoimmune diseases. But during that immune activation that happens at dialysis, there is a cross-activation of memory T cells. And what keeps the balance of the HLA antibodies, or what keeps the HLA antibodies from causing damage, is a balance between the memory T cells and the regulatory T cells. And it seems like patients with CD30 positive expression have lost that balance and they have more activation than inhibition. And so that identifies a subset of patients that really one should not try very much to go across a positive cross-match. And for these patients, the best thing is to just give them a transplant where they don't have antibodies to it. We need to understand the B cell. I'm going to spend a few minutes on this, and it seems like a little bit too much immunology, but we need to understand what happens to the B cells, and because the B cells are what's eventually differentiate into plasma cells that make the antibody. So B cells just wander in the body, they get antigen activation, and they need the T cells. So the B cells, in the presence of the T cell help, the naive B cells. We know that our bone marrow has, look, if you look at the diagram down on the right here, you can see that there is the formation in the bone marrow of pro-B cells or pre-B cells. The pre-B cells become immature B cells, transitional B cells, and then you get naive B cells. These cells have not seen antigen. They circulate in the blood. Now look on the left-hand side, and what happens is you get antigen activation. Now the B cell needs to respond to that antigen so it can secrete antibody that protects the individual. And there are two types of way to do that. One way is to create low affinity B cells that become differentiated into plasma cells. They secrete antibody immediately, and that antibody is low affinity antibody, but it helps opsonize the antigen and gets rid of it almost immediately. So the first step is an immediate step. Now, if you develop, there's another step to try to create now immunological memory so that when we meet that same antigen again, right, we have a better response to that than just trying to opsonize the antigen. And what happens is the B cells now start proliferate, go inside the lymph nodes, and inside the lymph nodes, they have to make a decision. The decision is, when they get into the germinal center of the lymph node, do they differentiate into germinal center independent B cells, or they become something else? In the germinal center B cells, these are the important ones, they now develop a B cell receptor, and that receptor goes through a process of somatic hypermutation and learns how to bind the antigen to which it came from. And only the cells that have high binding to that antigen then leave the lymph node and now go back into the bone marrow and sit there waiting for a second exposure. So that they form what we call long memory T cells. So these long memory T cells really stay around, and when they stay around, if the antigen is encountered again, they form immediately plasmablasts. So they bypass all of these steps. If you're looking on the right-hand side to my arrow, they bypass all of these steps of the activation that the regular B cell has to go through. They come from memory B cells, which is here by the red line. They become plasmablasts, and the plasmablasts make plasma cells, which immediately secrete antibody. And what's happening with the HLA complex is that exposure to that creates these long-lasting memory B cells in the bone marrow, in the lymph node, and in the circulation that continuously express anti-HLA antibodies. So this is summarized here. Again, the germinal center has three parts: proliferation, the B cells proliferate, and then the affinity maturation, which is the important step, because now they make antibodies, right, that are specific to the antigen we see. This is the worst step for our patients, which is class switching, because you can make an antibody to HLA B27 or 73, but after a certain amount of time, these cells continue to be active. In the patients that have an activated immune system, they get epitope spreading, they get class switching, they start making B27, A30, B7, whatever, they start making a very long list of antibodies. And some of us see those patients that have lists of antibodies that go for like half a page, patients that are going to be very hard to transplant. And We went over this. So we can actually detect those cells and can detect what antigen they are by doing an ELISA spot assay. And in an ELISA spot assay, you can immunize by the specific HLA antigen and then find the cells that are making cytokines to that, and you can detect it. This really we don't do in practice a lot. This is mostly a research test to try to localize what is the highest level of sensitization, not as expressed by antibodies, but the presence of the cell clones, so we can detect whether or not we're clearing these clones with the treatment. But it's a very interesting test because it can tell us, right, that in the immunized patients, there is a whole lot of activity related, and you can see in that upper graph here, A2 immunized, right? You can see the ELISA spot assay with a lot of cytokine production. So what are the desensitization strategies? I mean, we know we all desensitize using plasmapheresis, IVIG, and rituximab. But there are lots of other desensitization strategies based on the mechanism that I explored with you. We know rituximab is very important. And the reason rituximab is important, it clears out all the B cells, all the CD20 positive, which includes some of the memory cells. And so it's really very important in preventing the rebound that we get and in preventing hyperacute and accelerated acute rejection after transplant. So I think rituximab is one of the mainstays of our desensitization treatment. Now, CD40 ligand blockade really blocks the follicular helper T cells, and this is very important. I'm going to talk about that in detail. Of course, anti-BAFF drugs are now being used in the treatment of lupus, and there have been a lot of attempts to try to use them in transplantation. But what has been a little bit more successful is using anti-IL-6 monoclonal antibody, because it does inhibit the follicular dendritic cells, which actually result in the creation of the memory cells. So as you remove the antibodies, hopefully you prevent them from bouncing back so fast through the anti-IL-6, like tocilizumab. IDES, which is causes proteolytic antibody degradation, and enfuridumab, we're going to talk about that. Anti-CD38, again, it eliminates the short-term plasmablasts, so that, remember what I told you, that the memory B cells can quickly become plasmablasts that lead to the formation of plasma cells and secrete antibodies. So the anti-CD38 monoclonal antibodies treat that. There are also the JAK2 inhibitors and the attempt to expand ex vivo regulatory T cells, and actually the injection of regulatory T cells through the periphery, which is now very experimental. So what does that mean? I think the mainstay of our desensitization therapy has been IVIG. We don't really know how IVIG works, right? But we know that it causes B cell apoptosis, and maybe the Fc receptor mediated signal gets inhibited in the B cells. But it downregulates pro-inflammatory cytokines, and it inhibits complement-mediated inflammation. The advantage of IVIG is cheap, it's safe. A lot of our patients are Ig deficient, so it helps them. The problem with it is, as a single treatment, I'll show you later, it's not enough because there are pretty significant rebounds when you stop that treatment. It is used as an adjuvant, to plasmapheresis. And with rituximab, of course, there are several drugs like rituximab, but then you also have the proteasome inhibitors, proteasome inhibitors, such as bortezomib and carfilizumab, and these are really good because they do target a different compartment than what rituximab targets, so we can use them in conjunction with that, and we've had some reports in the literature about using that successfully to transplant some patients. I talked briefly about tocilizumab, which is an anti-IL-6, the IgG endopeptidases, and that cleaves the IgGs. Of course, belimumab, which is the BAFF inhibitors, eculizumab, which is the complement, blocks the complement C5, and it prevents the deposition or the attack of the antibodies into the cells, so that you can use that for rescue patients with antibody-mediated rejections. C1 esterase inhibitors, we have a trial doing that. the C1R and C1S. And actually, very anecdotal, we think we have some good results with that. And of course, belatacept, which is a CTLA-4 Ig, which affects the inhibition of plasma cell generation, which we use quite a bit now in desensitization. So if we go back to the IVIG, we know mechanism, as I said, we're not sure of. It doesn't affect the IgG subclass switching, the mutation frequency. So it doesn't really act on the IgG itself. It just downregulates the inflammatory response around IgG. Now, if you desensitize patients with or without rituximab, you see a significant difference, both in the graft survival and in the patient survival. So rituximab is very important. We shouldn't do plasmapheresis IVIG alone. Usually what we want to do is we want to introduce rituximab long before, 6 to 8 weeks before we start the plasmapheresis, because we want to give a chance for the rituximab to saturate all the peripheral and the central B lymphocytes so that we can get the best elimination and decrease the chance of rebound after plasmapheresis and IVIG. One of the very attractive things that I found, the Japanese really do that because they have a very large program of ABO and compatible transplants. And it really changed my mind about sensitization and desensitization, because most of the time we want to desensitize somebody within a month or 2 or 3 so we can do a transplant. But because I have a lot of patients on the cadaveric waiting list, which have time, I realized that the half-life of IgG antibodies is really long, 90 days or so. So it's easy to pull some antibodies out with plasmapheresis, but if you want to do any desensitization without plasmapheresis, it will take a very long period of time. So what we've developed and what Wade described in a single case that we've developed as a treatment is you can do a bit of plasmapheresis with IVIG, rituximab, plasmapheresis IVIG, and then place the patient on a single agent MMF, and you leave them on it for between 6 months and 12 months. And you will start seeing a very gradual, insidious, but continuous drop in the antibodies in the outer month. So we use that sometimes in patients that don't have a ready living donor transplant that are going to wait on the list. We know that CellCept is pretty safe for the majority of patients on dialysis. And so we give them small doses of that, leave them on them, and we hope that that is going to work. And it's been successful in a few patients in our experience. Now, the mechanistic handicap to the current techniques of sensitization is that plasma cells are not targeted directly by any of the drugs we use. The B cells lose the expression of CD20 when they get differentiated to PCs, plasma cells. Consequently, rituximab is going to be really very limited efficacy. It's only going to try to get the B cells before they change it to plasma cells. And bortezomib depletes the plasma cells, but does not reduce the level of DSA because there are some compensatory upstream germinal center expansion. So actually, what rituximab, bortezomib together do is they act on the cells that are already formed. But we know that we have these long-term memory cells that are hiding inside the bone marrow. They keep coming up, they keep going to the germinal cells, and as long as the germinal centers in the lymph nodes can make more plasma cells, the antibody levels that come down temporarily go back up again. So the solution is that you can multiply target the B cells. And this is what Stuart Knackley did. I call it the Knackley protocol. He did it in monkeys. He used CD28 and CD40 inhibition together with bortezomib, and so that he can actually target the B cell repertoire from all different directions. And if you look at what he did, bortezomib, co-stimulatory blockade with the anti-CD40, and then, of course, this leads to the disappearance of the CD20 cells from within the inside of the lymph nodes. You can see this is the CD20 cells almost completely gone from the germinal center. And the way they do that is by targeting the T follicular helper cell. The T follicular helper cell is very important because it promotes the differentiation of B cell into memory B cells, and if you block it, you prevent that antibody from coming back. We don't have anything. That CD40 antibody that he used is very experimental. We don't have it for patients. So the closest we have is hydrochloroquine. And hydrochloroquine is a really interesting drug. It inhibits the function of the antigen-presenting cell. It reduces the production of cytokines, including IL-1 and IL-6. So we know IL-6 is important in desensitization. It inhibits the activation of T cells and B cells. So that T-B cell help gets downregulated by hydroxychloroquine. And it binds and stabilizes to the DNA and inhibits migration of an inflammatory cell. So because it is targeting the T follicular helper cells, we thought that this would be a great addition to that multi-targeting protocol. And we created a protocol like that, where in week 1, we got the consent for the patient. We start belatacept, which is CD40 ligand blocker, and we start on Plaquenil. We give belatacept and Plaquenil, and once we've had enough Plaquenil in the system so that when we do the plasmapheresis, there isn't a huge rebound from the antibodies, we do plasmapheresis. That's 2 to 3 weeks after starting the Plaquenil, while continuing the Plaquenil. And then after that, on week 5, we now start the belatacept, we start the Kyprolis. And we give the Kyprolis on the same cycles, which is about 4 doses. That's 1 cycle. Wait a little bit while giving the belatacept and the Plaquenil, then repeat the Kyprolis cycle. Doing this, we were able to treat quite a few patients with desensitization. I'll show you one patient in a second. But another interesting thing is anti-CD38 therapy. We've tried 2 of these drugs, the daratumumab and one that is experimental by Sanofi in an experimental protocol. And these drugs, the daratumumab, when we used it for patients in collaboration with the belatacept, has been quite effective in lowering the antibody target. So I would encourage, if this is available, for people to try it. It's quite safe. Particularly, all of these patients need to be getting prophylaxis. So giving patients prophylaxis is very important. And finally, imlifidase, where actually it just cleaves the IgG antibodies. And if you can look at the curve here, the A and B is immediately after you give imlifidase, within hours, there are no IgGs, including all the HLA antibodies. And now they do come back starting on day 7 or so, and they come back to just about the same titers, or a little bit less than what they were. So the idea is it gives you a window, a few hours in which you can do a cross-match positive transplant. And this has been done and published by Bob Montgomery, and 89.5% of the patients had a conversion of a positive cross-match to a negative cross-match. That's an astounding rate. On the 90% of the patients, 9 out of 10, you give them the drug, their antibodies disappear, they become negative cross-match. The problem is the donor-specific antibody rebound, days 3 and 48. They had excellent patient and graft survival, but 40% of the patients have antibody-mediated rejection when the antibodies rebound. So you can't use it for everybody. The way to use it is to look at the repertoire of the antibodies and exclude the ones that are going to have a mismatch to an antibody with an MFI of 20,000, 30,000 or higher, because if these come back at these MFIs, it's going to be very hard to treat those antibody-mediated rejection. And here's a heart transplant patient that we treated. That patient got plasmapheresis, rituximab, bortezomib, daratumumab, and tocilizumab after transplantation when he had antibody-mediated rejection of the heart. Of course, here, there are no stops. It's not like a kidney patient. You have to treat. And this heart transplant patient is now 2 years out. First, they got desensitized to where they could get the transplant, as you see here. We got the antibody levels really down. But then when they had rebound after transplantation associated with rejection, we were able to treat them and remove the desensitization. Finally, I want to tell you that antibodies are not the only immunological risk for the highly sensitized patient. We know that there is also cellular sensitization. So all the cells, you can see them home, the plasmablasts, the plasma cells, memory B cells, the follicular helper T cells, the effector T cells, all of them are sensitized and they stay sensitized. But most importantly, the T cells also develop HLA sensitization. And you can identify that by some sophisticated testing in which you take T cells, you add a specific HLA antigen, they form a tetramer. And then if you double stain the tetramer and the CD8, you can see that the tetramer and the CD8, this indicates an HLA sensitized T cell. These cells produce B cell health and very high level of antibodies, and they can accentuate the mechanism of rejection. It's not all about the B cells, although this is our first barrier. So in summary, I want to tell you that the presence of preformed IgG anti-HLA antibody can be detected by our current technologies very effectively. The highly sensitized patient really has a high mortality if they remain on dialysis. The best option I find is to organ donor exchanges to find a compatible transplant. But desensitization also allows for transplants across some immunological barrier, although our protocol is standard desensitization protocols, plasmapheresis, rituximab, IVIG, and I didn't go into the detail of plasmapheresis. I know that in Egypt, there are a lot of people doing these protocols, so there's a lot of expertise there, that we use these for people with low levels DSA, somewhere less than 6,000 to 8,000 DSAs, MFIs, because we know that these are the borderline of a positive cross-match in our hand, so we can desensitize them that way and transplant them to their intended donor through these antibodies, with basically giving them thymoglobulin and post-transplant rituximab. So we give them a dose 3 months before the transplant, plasmapheresis and IVIG around the time of transplant, make sure they have a negative cross-match, transplant them with thymoglobulin, give them a second dose of rituximab 7 days after transplantation, and then follow them with protocol biopsies at 1 month and 6 months and a year. Now, there is advanced desensitization strategies, and I showed you some of them for the patients with high level of DSAs. They can get bortezomib, tocilizumab, daratumumab, belatacept, which I don't have on the slide here, which has been excellent, not only because you can give it pre-transplant to decrease the antibody levels, but also you maintain them on it post-transplant, so you prevent the rebound of the antibodies. I found belatacept to be one of the most effective tools that we've developed in our armamentarium now for desensitization. Finally, when all else you can do it, then you can try imlifidase, but you have to be very careful about the antibody rebound. And for patients where you need rescue, eculizumab is really important. You have a transplant, you start seeing very high level of DSAs with C1qs happen in the immediate post-transplant period. The graft is getting injury, particularly if you're transplanting a liver or a lung or a heart, then you can use eculizumab to rescue these organs. I want to thank you so much for listening to me. This is a very broad topic, and I hope I covered it enough, and I'll be more than happy to take questions. And I'm really pleased to speak to my colleagues, my friends in Egypt, and I hope to be there soon so we can see you and speak in person. Thank you so much.